Welcome back to the deep dive. Whenever we sift through a stack of sources, we're usually looking for those subtle shifts in how we understand a field.
Right, the turning points.
Exactly. And today, we are focusing our attention on a very specific piece of anatomy, the inguinal canal.
It is a fascinating area.
It really is. We're drawing heavily today from Dr. Senthil Kumaran's comprehensive masterclass. It covers inguinal hernia repairs, surgical complications, and the whole complex decision-making matrix that dictates operative strategy.
And I think it's important to state up front that our mission for this deep dive isn't just to review the basic anatomy.
Right, because if you're listening to this, you likely already know the borders of Hasselbalch's triangle. You don't need us to list them.
No, absolutely not. Our goal is to deconstruct the biomechanical and historical logic behind these techniques.
The why.
Exactly, the why. Why do surgeons approach the fascial planes the way they do? How has the whole philosophy of managing intra-abdominal pressure evolved over the last 150 years?
Because when you look at it closely, it really is a story about structural engineering.
It is entirely an evolution of structural engineering applied to human biology. Because when you strip away the routine nature of this procedure, you are fundamentally looking at a structural failure in a dynamic pressure vessel.
A pressure vessel, right, the human abdomen.
Yes, the abdomen is constantly subjected to massive fluctuations in hydraulic pressure.
From coughing, lifting, straining.
Just daily living. And the posterior wall of the inguinal canal is the inherent weak point in that vessel.
So the entire history of this specific surgical field is really just a chronological study of the incredible lengths we've gone to in order to patch that defect.
Right, to patch it against the relentless force of intra-abdominal pressure.
And to really understand the modern landscape, you have to start by looking at the core problem. Every single hernia repair technique in history is an attempt to permanently restore that failed posterior wall.
But the approach to doing that is divided by a massive philosophical schism.
A schism that has persisted for decades. On one side, you have the tissue-based tension repairs.
Right, the philosophy of autologous reconstruction.
Using the patient's native fascial and eponeurotic structures. And then on the other side, you have the tension-free prosthetic era.
Which argues that native tissues failed for a biomechanical reason in the first place.
Right, so relying on them again is essentially an architectural fallacy.
That paradigm shift from tension to tension-free is arguably one of the defining moments in modern general surgery.
But we can't critically evaluate the mesh revolution without first conducting a deep dive into the tissue architects who preceded it.
The surgeons of the late 19th and early 20th centuries, they were laying down the anatomical blueprints that we still rely on today.
Okay, let's unpack this. We have to look closely at Edoardo Bassini.
Bassini in 1887.
Right, let's contextualize 1887 for a second. We are in the pre-Listerian or, well, just barely post-Listerian era of surgery.
Antisepsis is rudimentary at best.
And anesthesia is incredibly volatile. So before Bassini, operative intervention for an inguinal hernia was really a salvage procedure.
It had astronomical recurrence rates, frequently hovering around 40%.
40%. So you were subjecting a patient to severe operative morbidity for what was basically a coin flip chance of a durable repair.
Bassini's contribution was transformative because he recognized that previous attempts were merely superficial closures.
They were just treating the symptom.
Exactly, just tying off the protruding sac without addressing the foundational structural failure.
But Bassini understood the anatomy. He knew the transversalis fascia was the critical load-bearing layer.
Yes. His anatomical breakdown of the problem was the first truly reproducible, biomechanically sound surgical intervention for this pathology.
Let's break down the exact mechanics of Bassini's repair, because as you mentioned, it's the bedrock of anterior tissue reconstruction. He didn't just pull the hole closed.
No, he utilized a 3-layer repair.
Right, unifying the transversalis fascia, the internal oblique muscle, and the transversus abdominis muscle.
Precisely. Bassini realized that these native tissues, if you look at them individually in a hernia patient, they are often attenuated and friable.
They're weak.
Very weak. So his principle was to recruit the combined tensile strength of all 3 layers.
So he aggressively dissected these planes.
And then sutured them together as a single, consolidated, full-thickness aponeurotic and muscular unit.
And then he anchored that massive combined unit directly to the inguinal ligament.
Essentially creating a newly fortified posterior wall from scratch.
And the key spatial maneuver here is that he did this posterior to the spermatic cord.
Right. He recognized that the internal ring had lost its integrity.
So he reconstructed the anatomy from the floor up. He created a new internal ring and placed the spermatic cord anterior to this newly constructed wall.
Just deep to the external oblique aponeurosis. The biomechanical result of this was staggering for the era.
Because by establishing this unified, tension-bearing posterior wall, that recurrence rate plummeted.
From 40% down to under 10%.
Which is incredible. It proved that the anatomy could be fundamentally rearranged to resist intra-abdominal pressure.
Now, a pure Bassini repair is infrequently performed in contemporary practice.
Due to the tension it creates, right?
Exactly. But it established the anatomical dissection planes for literally every procedure that followed.
Which brings us to that concept of tension. And that leads us to the absolute zenith of the tissue repair philosophy.
The Shouldice technique.
Right, the Shouldice Hospital in Toronto. They operate as a high-volume center entirely dedicated to non-prosthetic native tissue repair.
They still do it today.
And in an era where polypropylene mesh is ubiquitous, they are achieving recurrence rates of less than 1%, using solely the patient's fascial structures.
It is remarkable.
So, mechanically speaking, what is the Shouldice repair doing that the Bassini doesn't?
The Shouldice repair is really a masterclass in managing fascial tension and maximizing collagen cross-linking.
Okay.
It is a 4-layer continuous suture repair, and it begins with a highly specific maneuver.
Step 1.
Step 1. The complete longitudinal incision of the transversalis fascia from the internal ring all the way down to the pubic tubercle.
Which, if you think about it, seems entirely counterintuitive at first glance. You have a patient with a weak wall, and step 1 is to slice it completely open.
It does seem completely backward, but it allows for the mobilization of the superior and inferior fascial flaps.
Okay.
Once those are mobilized, the surgeon imbricates these flaps.
They overlap them.
Exactly. They pull the inferior flap up and deep to the superior flap, suturing it in place, and then they fold the superior flap down over the inferior flap, and they suture that down as well.
So it's double-breasted. You are effectively doubling the cross-sectional thickness of the transversalis fascia.
It is a laminated fascial reinforcement.
So that handles the foundational layer. Then for the second stage, they deploy 2 additional continuous suture lines.
Right. They approximate the internal oblique and the transversus abdominis or the conjoint tendon, depending on the patient's anatomical variation, down to the inguinal ligament.
Again, overlapping the previous layers.
The defining biomechanical principle here is the difference between physiological tension and excessive tension.
Explain that difference.
Tissue healing actually requires some degree of mechanical stress.
To stimulate the cells.
Yes, to stimulate proper fibroblast orientation and collagen deposition. However, excessive tension creates shear stress.
Right.
If you put too much tension on a fascial edge, the sutures induce local tissue ischemia.
The blood flow gets cut off.
The tissue undergoes necrosis, the suture physically cuts through the fascia, and the repair fails.
But the Shouldice technique avoids this.
Right. By utilizing continuous monofilament or wire sutures, it distributes the tension evenly across the entire length of the canal.
So you get a snug physiological apposition without that ischemic shear stress.
Exactly.
But let's look at the systemic applicability of this, because you have to wonder, if the Shouldice clinic achieves less than a 1% recurrence rate without using any foreign bodies, why isn't this the universal standard?
That is the big question.
Isn't the reliance on mesh just a systemic crutch for surgeons who lack the specialized fascial precision required for a perfect Shouldice?
That is exactly the debate that defines the literature on this topic.
I bet.
The reality of surgical training and general practice dictates our standards. The Shouldice repair is profoundly operator-dependent.
Meaning it relies heavily on the skill of the specific surgeon.
It requires a meticulous, almost uncompromising understanding of the local fascial planes and daily repetition.
Which they have at the Shouldice Hospital.
Right. The surgeons there perform this exact operation thousands of times. But when this specific technique is exported to general surgical practice,
where a surgeon might only do a few inguinal hernias a month, mixed in with gallbladders and bowel resection.
Exactly. In those hands, the recurrence rate of the Shouldice climbs to between 1% and 3%, and sometimes even higher.
So the technique itself is entirely unforgiving of anatomical imprecision or slight misjudgments in tension.
It is.
So, in the modern algorithm, when do we actually deploy the Shouldice? Because Dr. Kumaran's framework outlines specific clinical scenarios where it is still used.
It remains highly indicated for young patients.
Because putting a permanent synthetic mesh in a 20-year-old carries unknown long-term foreign body risks over a 50-year lifespan,
Right. It is also utilized in grossly contaminated surgical fields.
where a permanent macroporous mesh would inevitably harbor a biofilm and get infected.
And of course, it's used for patients who explicitly refuse prosthetic implants.
Makes sense. Now, before we transition away from the tissue architects, we have to address the McVeigh, or Cooper's ligament repair.
We do, because it solves a distinct anatomical vulnerability that neither Bassini nor Shouldice adequately covers.
The femoral space.
Exactly. Bassini and Shouldice both utilize the inguinal ligament as their inferior anchoring structure.
But the inguinal ligament bridges right over the femoral vessels and the femoral canal.
So if you have a concomitant femoral hernia, or if the inguinal ligament has been obliterated by previous surgical interventions,
Suturing to it is either impossible or it just completely ignores the actual pathology.
precisely. So the McVeigh repair drops the foundational anchor point deeper into the pelvis.
Instead of suturing the transversus abdominis aponeurosis and transversalis fascia to the inguinal ligament, the surgeon bypasses it entirely,
And sutures directly to Cooper's ligament.
which is that dense, unyielding periosteal reflection along the pectineal line of the superior pubic ramus.
And the massive mechanical advantage of utilizing Cooper's ligament is that you completely obliterate the femoral ring from an anterior approach.
You are sealing off the space medial to the femoral vein, so it is the only classic anterior tissue repair that effectively manages a femoral hernia.
But the biomechanical cost is immense.
Because by pulling the superior aponeurotic structures all the way down to the pectineal line, you are bridging a massive anatomical gap,
The tensile force required to approximate those tissues is extraordinary.
far exceeding physiological tension.
The shear stress on the suture line would virtually guarantee failure under the normal fluctuations of intra-abdominal pressure.
So to mitigate that, the surgeon has to physically alter the superior anatomy.
They do. They must perform a relaxing incision in the anterior rectus sheath.
Describe that.
They make a vertical paramedian incision through the aponeurosis of the anterior rectus sheath, extending superiorly from the pubic crest.
And that allows the lower abdominal musculature to physically slide inferiorly.
Dramatically reducing the tensile load on the suture line at Cooper's ligament.
It's an aggressive structural modification. You are intentionally compromising the structural integrity of the medial fascial column just to facilitate the closure of the inferior pelvic defect.
It's a drastic intervention. It really highlights the lengths they had to go to overcome the inherent limits of native tissue compliance.
And the recognition of those limits, the fact that pathological tension inevitably leads to fascial failure, that was the primary catalyst for the most radical shift in modern hernia surgery.
Which brings us to 1989,
Irving Lichtenstein.
the publication of his seminal paper on the tension-free hernioplasty.
Let's examine Lichtenstein's core thesis, because he analyzed the long-term data of the tissue era, and he concluded that autologous repairs, regardless of how elegantly they were designed, possess an inherent failure rate.
Because they rely on pulling attenuated pathological tissue across a dynamic defect.
So his proposition was just to abandon the pursuit of fascial approximation entirely.
Right. Instead of stretching the patient's faulty tissue under tension, the surgeon bridges the defect with a prosthetic scaffold.
A synthetic mesh.
It is an externalization of the structural support.
Because the abdominal wall in these patients lacks the inherent tensile strength to contain the visceral pressure anyway.
Lichtenstein's approach provides an inert synthetic skeleton.
The mesh acts as a framework for fibroplasia.
Exactly. Macrophages and fibroblasts infiltrate the interstices of the polypropylene mesh. They deposit collagen and create a dense, integrated fibrotic wall.
And that new fibrotic wall bears the mechanical load, completely sparing the native fascia from any shear stress.
And the clinical efficacy was immediate and undeniable.
Recurrence rates across all levels of surgical expertise dropped to between 1% and 2%.
It democratized the hernia repair. It removed the extreme operator dependence of the Shouldice.
Let's trace the operative steps of the open Lichtenstein, because the nuances of this procedure dictate its success or failure.
The standard approach utilizes an oblique incision. It's positioned 2 finger breadths superior and parallel to the medial 2/3 of the inguinal ligament.
The dissection carries down through the subcutaneous tissues.
Through Scarpa's fascia until the external oblique aponeurosis is visualized and incised through the superficial inguinal ring.
And the moment you open the external oblique and enter the inguinal canal, you are navigating one of the most clinically sensitive neurological territories in the human body.
It is a minefield.
Dr. Kumaran's material heavily emphasizes the identification and preservation of the three primary sensory nerves of the groin.
The ilioinguinal nerve, the iliohypogastric nerve, and the genital branch of the genitofemoral nerve.
The neuroanatomy here is paramount. Walk us through it.
The ilioinguinal nerve typically emerges from the lateral border of the psoas major, pierces the internal oblique, and runs anterior to the spermatic cord within the canal.
Okay.
The iliohypogastric runs superior to the canal, often just under the external oblique aponeurosis.
And the third one.
The genital branch of the genitofemoral nerve. It actually enters the canal through the deep inguinal ring, running intimately within the cremasteric fascia of the cord itself.
Now, the stakes regarding these nerves cannot be overstated. If you're listening to this, you need to understand we aren't just trying to avoid a minor sensory deficit here.
Not at all.
If one of these nerves is crushed by a forceps or caught in a permanent proline suture, or even eventually entrapped within the fibrotic reaction of the mesh integration,
The patient develops severe chronic neuropathic pain.
we are talking about debilitating hyperalgesia and allodynia radiating into the inner thigh and scrotum or labia.
Therefore, meticulous atraumatic isolation of these nerves is the absolute prerequisite before any mesh is ever deployed.
Once the neurovascular structures are secured and the spermatic cord is mobilized, the hernia sac is managed.
Either inverted or ligated at the level of the internal ring.
And then the surgeon introduces the prosthesis. The standard is a macroporous polypropylene mesh.
Typically measuring 7.5 by 15 centimeters.
It is laid down to completely blanket the posterior wall defect. But because the spermatic cord must traverse this plane to reach the scrotum, the mesh can't just be a solid, continuous sheet.
Right, it would block the cord. So to accommodate it, the surgeon makes a precise longitudinal slit in the lateral aspect of the mesh,
Creating two tails.
This forms a keyhole. The mesh is passed around the spermatic cord so that the cord emerges through the apex of this keyhole,
And then the superior tail is crossed over the inferior tail, and they are sutured together.
effectively recreating a snug, highly reinforced internal inguinal ring.
The fixation of the rest of the mesh is equally protocolized. Inferiorly, it is secured to the shelving edge of the inguinal ligament with a continuous suture.
Superiorly, it is fixed to the internal oblique aponeurosis, being incredibly careful to avoid the iliohypogastric nerve.
But the most critical biomechanical detail of the fixation occurs medially.
At the pubic tubercle.
This is a detail where surgical physics perfectly intersects with biology. The mesh must be tailored to overlap the pubic tubercle by exactly a minimum of 2 centimeters.
Yes.
Now, you might wonder why that specific dimension. Why isn't edge-to-edge approximation sufficient?
Because polypropylene mesh, while inert, induces a robust foreign body inflammatory response.
Right.
As the fibroblasts infiltrate and the collagen matrix matures over the subsequent months, the scar tissue contracts.
This biological contraction physically shrinks the dimensions of the mesh implant.
By up to 20%.
Wow. So if a surgeon trims the mesh precisely to the medial border of the pubic tubercle, the subsequent contraction will pull the mesh laterally.
Exposing the medial aspect of the posterior wall and creating a direct pathway for a recurrence.
It is fascinating that the primary cause of recurrence in the Lichtenstein repair isn't a material failure of the mesh itself, but a failure to account for the biomechanical vector of tissue contraction.
That 2-centimeter overlap ensures that even after maximum fibrotic shrinkage, the dense periosteal anchor at the tubercle remains completely covered.
So the Lichtenstein really solved the tension dilemma for the anterior approach. However, the next monumental leap in hernia surgery wasn't about changing the material.
No, it was about fundamentally altering the anatomical plane of the repair.
It was the transition to the preperitoneal space during the laparoscopic revolution.
To understand the superiority of the laparoscopic approach, you have to look at the fluid dynamics of the abdominal cavity.
Right, think about an open Lichtenstein. The mesh is placed on the anterior surface of the transversalis fascia.
So the intra-abdominal pressure is pushing outward, constantly exerting force against the mesh fascia interface.
Essentially trying to blow the patch off the wall from the inside.
The repair is entirely reliant on the strength of the sutures and the fibrotic integration to resist that outward pressure.
But the laparoscopic approach flips that dynamic entirely.
By accessing the preperitoneal space, which is the avascular plane situated between the transversalis fascia anteriorly and the parietal peritoneum posteriorly, the surgeon places the mesh on the inside of the abdominal wall defect.
It leverages Pascal's principle.
Exactly. The intra-abdominal pressure is now distributed evenly across the posterior surface of the mesh, actively compressing it against the anterior abdominal wall.
So the physiological force that previously caused the hernia is now the exact mechanism holding the prosthetic scaffold permanently in place.
It is biomechanically elegant.
But beyond the physics of pressure, the preperitoneal approach provides an unmatched anatomical vantage point.
It allows for the complete visualization and coverage of the myopectoneal orifice of Frouchot.
Let's detail Frouchot's orifice, because it is the defining anatomical concept of modern, minimally invasive hernia surgery.
Henri Frouchot recognized that the groin shouldn't be viewed as separate, distinct weaknesses.
Right, not just a direct spot here and an indirect spot there.
It should be viewed as one contiguous area of vulnerability. The myopectoneal orifice is bound superiorly by the internal oblique and transversus abdominis muscles, inferiorly by the pectoneal line of the pubis, medially by the lateral border of the rectus sheath, and laterally by the iliopsoas muscle.
And it is bisected by the inguinal ligament. Crucially, every single type of groin hernia, direct, indirect, and femoral, originates through a subdivision of this single massive orifice.
So when a surgeon performs a laparoscopic repair, they aren't just patching the specific direct or indirect defect, they diagnose clinically in the office.
They utilize a massive piece of mesh
Minimally 15 by 10 centimeters.
that blankets the entire myopectoneal orifice of Frouchot. They are prophylactically reinforcing the direct space, the deep ring, and the femoral canal all simultaneously.
To achieve this, the surgeon must navigate into the preperitoneal space, which brings us to the two dominant laparoscopic techniques.
TAPP, the totally extraperitoneal approach, and TAPP, the transabdominal preperitoneal approach. Let's analyze the procedural depth of TAPP first.
TAPP is minimally invasive surgery taken to its logical extreme.
The surgeon makes an infraumbilical incision and dissects down to the anterior rectus sheath, incising it to expose the rectus abdominis muscle.
They retract the muscle laterally to expose the posterior rectus sheath, and then they advance a balloon dissector directly into the preperitoneal space.
The balloon dissection is a critical step here.
By inflating the balloon, the surgeon bluntly separates the delicate visceral peritoneum from the posterior aspect of the transversalis fascia and the rectus musculature,
They are physically creating a working cavity within what is normally just a potential space.
expanding the space of Retzius medially over the bladder and the space of Bogros laterally.
Once the cavity is created, they insufflate it with carbon dioxide to maintain the workspace.
The primary advantage of TAPP is that the peritoneal cavity is never actually breached.
The abdominal organs remain completely undisturbed behind the peritoneal envelope.
This virtually eliminates the risk of visceral injury during dissection and prevents the formation of intra-abdominal bowel adhesions to the mesh or trocar sites.
However, the learning curve for TAPP is exceptionally steep. The anatomical landmarks look vastly different from this limited posterior perspective.
Furthermore, the working space is highly constrained. If the surgeon inadvertently tears the extremely thin peritoneum during dissection,
The carbon dioxide insufflation gas will rapidly leak into the main peritoneal cavity.
which equalizes the pressure, causing your preperitoneal working space to just completely collapse.
A phenomenon known as loss of domain. In severe cases, this necessitates an immediate conversion to a TAPP, or open procedure.
Which perfectly frames the utility of the TAPP repair. If TAPP avoids the peritoneal cavity, why would a surgeon intentionally choose TAPP, which requires entering the main abdominal compartment?
Well, TAPP is essentially the transperitoneal route to the extraperitoneal space.
Right, the surgeon places their trocars directly into the abdominal cavity, establishing a standard pneumoperitoneum.
From inside, they have a panoramic, wide-angle view of the posterior groin anatomy.
But to place the mesh, they must surgically incise the parietal peritoneum from the inside,
creating a large peritoneal flap extending from the medial umbilical ligament laterally to the anterior superior iliac spine.
They raise this flap, expose the myopectoneal orifice of Frouchot, reduce the hernia sac, lay down the large macroporous mesh over the entire defect, and then, and this is critical, they must meticulously reapproximate and close that peritoneal flap over the mesh using sutures or tacks.
That closure is mandatory. If you are a student visualizing this, remember, if the mesh is left exposed to the intra-abdominal cavity, the bowel will aggressively adhere to the polypropylene.
leading to catastrophic mechanical bowel obstructions or intercutaneous fistulas.
The advantage of TAPP, though, is the expansive visualization of the larger working domain, making it easier to identify the anatomy and manipulate the mesh.
So we have the open Lichtenstein, TAP, and TAPP. How does a surgeon rapidly triage a patient into the correct operative pathway?
Dr. Kumaran's masterclass provides a highly specific decision matrix based on clinical presentation. Let's run through these scenarios. Let's consider a patient presenting with bilateral inguinal hernias.
In this scenario, TAP is the gold standard. When you develop the preperitoneal space with the balloon dissector, you easily expose the space of recurrence crossing the midline. You create one contiguous bilateral cavity.
So you can repair both the left and right myopectoneal orifices sequentially through the same 3 midline trocars without needing to make new incisions or enter the peritoneal cavity. Makes perfect sense. What if a patient presents with a recurrent hernia after a previously failed open Lichtenstein repair?
A prior anterior repair means the anterior fascial planes, the external oblique aponeurosis, and the inguinal canal are obliterated by dense fibrotic scar tissue.
Attempting to dissect through that anterior scarring risks severe damage to the cord structures and the sensory nerves.
So the logical surgical principle is to approach the recurrence through virgin tissue planes. Therefore, a posterior laparoscopic approach, either TAPP or TAPP, is strongly preferred, completely bypassing the anterior scar tissue.
Okay, let's flip that. What if the patient has a primary inguinal hernia, but their surgical history includes a previous lower midline laparotomy, perhaps for a perforated diverticulum or a prostatectomy?
In that case, TAPP is generally contraindicated.
Because a previous lower midline incision almost certainly means the preperitoneal space of recurrence has been destroyed by postoperative scarring.
If you attempt to force a balloon dissector through that midline scar tissue, you will simply rupture the peritoneum or severely damage the bladder.
So for this patient, TAPP is the laparoscopic procedure of choice.
Right. You enter the abdominal cavity, directly visualize the extent of the pelvic adhesions, and navigate laterally to create your peritoneal flap, avoiding the midline scarring entirely.
And what if the patient presents with a grossly contaminated field, for example, a strangulated hernia where the bowel has perforated, leading to fecal peritonitis in the groin?
Laparoscopic approaches using synthetic mesh are absolutely contraindicated.
Placing a permanent macroporous polypropylene mesh into a field with active bacterial contamination guarantees a chronic mesh infection.
The bacteria will colonize the plastic interstices, creating an impenetrable biofilm that systemic antibiotics cannot reach.
So the required approach is an open autologous tissue repair like a Bassini or Shouldice.
Or the use of a highly specialized, fully biological, resorbable extracellular matrix that can withstand the contaminated environment while providing temporary tensile support.
That discussion of strangulation perfectly bridges into the most critical segment of hernia management, the high-stakes, emergency intraoperative scenarios.
Right. Regardless of whether you're performing an open or laparoscopic repair, human anatomy dictates that you will encounter unpredictable and potentially lethal variations.
Let's analyze the pathology of the sliding hernia.
A sliding hernia represents a profound anatomical trap.
In a standard indirect hernia, the sac is composed entirely of a protrusion of the parietal peritoneum.
The surgeon's goal is to dissect the sac away from the cord structures, ligate it at the neck, and resect the redundant tissue.
However, in a sliding hernia, a retroperitoneal organ actually forms a portion of the wall of the hernia sac itself.
Because of the asymmetrical reflection of the visceral peritoneum over the retroperitoneal structures, as the peritoneal sac is pulled down into the inguinal canal, it drags the attached organ with it.
On the left side, the posterior wall of the sac is frequently formed by the sigmoid colon.
On the right side, it is often the cecum.
Medially, particularly in direct hernias, the sliding component can be the wall of the urinary bladder.
The clinical danger is immediate.
If a surgeon assumes they are dealing with a standard peritoneal sac and blindly places a crushing clamp across the base to resect it,
they will amputate a segment of the sigmoid colon or the bladder.
it is a devastating iatrogenic injury.
The operative management requires the Lahey technique.
Explain how.
The surgeon must recognize the thickened, vascularized nature of the sac wall. They must painstakingly dissect the visceral peritoneum away from the true sac, gently mobilize the viscus, and reduce the organ back into the retroperitoneal space before managing the remaining true peritoneal sac.
Clinically, a surgeon must have a high index of suspicion for a sliding hernia when evaluating an older male patient presenting with a massive, chronic, irreducible scrotal hernia.
That specific phenotype strongly suggests that a major visceral organ has descended into the scrotum.
Let's move to the ultimate surgical emergency in this field, the strangulated hernia.
This is the transition from a mechanical defect to an acute ischemic crisis.
The pathophysiology of strangulation is a rapid cascading sequence. A segment of bowel herniates through the fascial defect.
The rigid fascial ring acts as a tourniquet. Initially, the low-pressure venous outflow is occluded.
The bowel loop rapidly becomes engorged and edematous.
This swelling further increases the pressure within the confined space of the hernia sac until it exceeds the arterial perfusion pressure.
At that moment, arterial inflow ceases.
The bowel wall becomes acutely ischemic. Hypoxia leads to mucosal sloughing, bacterial translocation across the gut wall, and eventually full-thickness transmural necrosis and perforation.
The patient presents in extremis, excruciating focal pain over an irreducible mass, accompanied by systemic toxicity, tachycardia, and classic signs of mechanical bowel obstruction.
In the operating room, the immediate imperative is to release the constricting fascial ring to restore perfusion.
But the anatomy dictates exactly where that releasing incision must be made. If it is an indirect inguinal hernia, the constriction is at the deep inguinal ring.
Dr. Kumaran emphasizes that the surgeon must incise the ring anteriorly and laterally.
Why laterally? Because immediately medial to the deep ring lie the inferior epigastric vessels.
An errant medial cut will transect the inferior epigastric artery, causing massive retroperitoneal hemorrhage.
The anatomical stakes are even higher with a strangulated femoral hernia. The constricting point is typically the rigid lacunar ligament on the medial aspect of the femoral ring.
To release the bowel, the surgeon must sharply incise the lacunar ligament medially.
However, this maneuver exposes the surgeon to one of the most feared anatomical anomalies, the corona mortis.
The crown of death.
This is an aberrant vascular anastomosis connecting the obturator artery systems with the external iliac or inferior epigastric systems. It arcs directly over the posterior aspect of the superior pubic ramus, resting immediately adjacent to the lacunar ligament.
And its prevalence is alarmingly high. It's present in 20 to 30% of the population.
If a surgeon blindly incises the lacunar ligament to relieve a femoral strangulation and transects the corona mortis,
the severed ends of the artery immediately retract deep into the pelvic fascia. It produces a catastrophic torrential hemorrhage into the retropubic space that is incredibly difficult to access and control in an emergency setting.
the surgeon must meticulously define the medial border of the ligament and secure hemostasis of any aberrant vessels prior to releasing the constriction.
Assuming the ring is safely divided, the surgeon extracts the herniated bowel. They must now make a definitive judgment on tissue viability. They cannot simply observe it. There's a standardized physiological assessment.
Right. The ischemic bowel will appear cyanotic, edematous, and devoid of peristalsis.
The surgeon must wrap the affected segment in laparotomy sponges soaked in warm saline and wait for 5 uninterrupted minutes.
The warmth promotes vasodilation and mitigates vasospasm. After 5 minutes, they assess the physiological markers of recovery.
Does the serosa return to a healthy pink hue? Do the mesenteric arteries show palpable pulsations? Does mechanical stimulation elicit visible peristaltic waves?
If those signs are absent, the transmural necrosis is irreversible.
The necrotic segment must be completely resected and a primary bowel anastomosis performed. And as we discussed earlier, the presence of necrotic bowel dictates the strict avoidance of any synthetic mesh due to the massive bacterial load now present in the surgical field.
There is one more complex anatomical presentation that requires precise intraoperative diagnosis: the pantaloon hernia, designated as a Gilbert type 6 defect.
The pantaloon hernia is a simultaneous presentation of both a direct and an indirect inguinal hernia on the ipsilateral side.
The direct component protrudes medially through Hasselbalch's triangle, while the indirect component descends laterally through the internal inguinal ring.
They are physically separated by the inferior epigastric vessels, resembling the legs of a pair of trousers straddling the vasculature.
The profound risk here during an open anterior repair is missed pathology. A surgeon may easily identify a large indirect sac, dissect it, and repair the internal ring, completely failing to explore the floor of the canal, where a massive direct defect is hiding medial to the epigastric vessels.
The patient experiences an immediate postoperative recurrence.
This is where the peritoneal laparoscopic approach demonstrates absolute superiority.
When viewing the myopectoneal orifice from the posterior perspective in a TEP or TPOPP procedure, both the direct space and the deep ring are simultaneously visible in the same panoramic field.
The single large mesh prosthesis intrinsically covers both defects, eliminating the risk of overlooking a concurrent pantaloon component.
Once the anatomy is repaired and the patient is closed, the surgical focus immediately shifts to the postoperative phase. The analysis of complications is critically divided by temporal onset, immediate, early, and late.
This timeline dictates the pathophysiological differential diagnosis. Immediate complications occurring intraoperatively or in the PCU are almost exclusively mechanical or hemorrhagic. We've discussed the vascular risks regarding the inferior epigastric vessels and the corona mortis.
There is also the risk of direct visceral trauma, particularly bladder injury during the dissection of the medial direct space, or iatrogenic anerotomy during the establishment of laparoscopic trocars, or the reduction of densely adherent sliding hernias.
As we move into the early postoperative period, the first 24 to 72 hours, the physiological responses to the surgery dominate the clinical picture. And surprisingly, the most frequent complication across all demographics isn't a hematoma or an acute surgical site infection. It is acute urinary retention.
The pathophysiology of postoperative urinary retention is multifactorial, particularly in elderly men with pre-existing benign prostatic hyperplasia.
You have the lingering pharmacologic effects of volatile anesthetics and opioids, which depress the detrusor muscle contractility.
Concurrently, the localized trauma and acute inflammatory response in the groin induce reflex sympathetic overactivity, increasing the tone of the internal urethral sphincter.
The bladder distends, but the outflow tract is functionally obstructed. These patients frequently require transient catheterization until the sympathetic tone normalizes.
Another severe early complication that must be aggressively monitored is ischemic orchitis. This typically manifests on postoperative day 2 or 3 as acute, excruciating testicular pain accompanied by profound swelling and induration.
Ischemic orchitis is an impending disaster for the testicle. It is rarely caused by direct transection of the testicular artery.
Rather, it is typically secondary to extensive traumatic dissection of a large, chronically adherent distal hernia sac from the spermatic cord.
This overzealous manipulation causes venous thrombosis within the pampiniform plexus.
The impaired venous outflow leads to severe testicular congestion, edema, and secondary arterial compromise. While the acute inflammation may subside with supportive care, the long-term sequela is often irreversible testicular atrophy due to the hypoxic insult to the seminiferous tubules.
Transitioning to the late complications, those presenting months or years postoperatively, we encounter the true durability tests of the repair. Recurrence is obviously a primary concern, directly correlated to technical failures like inadequate mesh overlap or missed concurrent defects.
There is also the insidious threat of deep mesh infection, where a dormant bacterial biofilm on the avascular polypropylene matrix suddenly flares, necessitating the complete surgical explantation of the integrated mesh to achieve source control.
But the most statistically significant and functionally debilitating late complication is chronic neuropathic groin pain. Dr. Kumaran's data highlights that this affects up to 10% of patients following hernia repair.
This isn't nociceptive somatic pain from the incision. It is severe intractable neuropathic pain resulting from the direct injury or entrapment of the ilioinguinal, iliohypogastric, or genitofemoral nerves.
The mechanism of entrapment is usually either a suture inadvertently catching the epineurium or the nerve becoming encased in the dense fibrotic scar tissue contracting around the mesh implant. The resulting allodynia can severely limit mobility and quality of life.
The incidence of this debilitating complication has led to a highly pragmatic, though aggressive, surgical strategy during open repairs. Given the difficulty of reliably dissecting and preserving these delicate nerves in a scarred or highly inflamed field, many high-volume surgeons opt for prophylactic neurectomy.
If they identify the ilioinguinal nerve, rather than attempting to meticulously mobilize it and risk subsequent fibrotic entrapment, they intentionally and cleanly transect the nerve.
They allow the proximal stump to retract deep into the internal oblique muscle, physically removing it from the inflammatory milieu of the mesh.
It is a calculated anatomical trade-off. By severing the sensory nerve, the surgeon unequivocally eliminates the pathway for neuropathic entrapment pain.
The physiological cost is a predictable, localized area of cutaneous anesthesia over the ipsilateral base of the penis or mons pubis and the supramedial thigh.
Clinically, the vast majority of patients easily tolerate this discrete sensory deficit, considering it a highly favorable alternative to a 10% risk of permanent agonizing neuralgia.
Let's round out this deep dive by examining some of the more complex and deceptive clinical presentations in herniology. Dr. Kumaran outlines several specific hernia variants that demand precise diagnostic acumen because their anatomical behavior deviates from standard presentations. Let's run through these classic diagnostic traps.
We must start with the epidemiological baseline. The indirect inguinal hernia is the most prevalent hernia variant across the entire population. Notably, despite the anatomical differences in the female pelvis, the indirect inguinal hernia remains the most common groin hernia in women as well.
While femoral hernias have a higher relative incidence in females compared to males due to the widened pelvic inlet, in absolute clinical numbers, indirect hernias still dominate.
But when we assess the risk of acute strangulation, the femoral hernia is the most dangerous variant. The borders of the femoral ring, the inguinal ligament, the pectineal ligament, and the rigid lacunar ligament are unyielding aponeurotic and periosteal structures.
Any visceral contents that protrude into this narrow canal are subjected to intense mechanical compression, accelerating the ischemic cascade far more rapidly than within the more compliant tissues of the inguinal canal.
Regarding the contents of the hernia sac, while we frequently discuss strangulated bowel, the most commonly incarcerated intra-abdominal structure is actually the greater omentum. Let's discuss the specific mechanical variants of bowel herniation. The Richter's hernia presents a unique diagnostic challenge.
A Richter's hernia occurs when only a partial circumference of the bowel wall, specifically the antimesenteric border, is incarcerated within the fascial defect.
The clinical danger is severe because the lumen of the dowel remains patent. The patient may continue to pass flatus and stool, completely lacking the classic systemic signs of mechanical bowel obstruction, like intractable vomiting or obstipation.
Exactly. The lack of obstructive symptoms delays the clinical presentation. Meanwhile, the tightly pinched antimesenteric wall is undergoing focal ischemia and rapidly progressing to necrosis and localized perforation, often presenting late as an acute localized abscess or severe peritonitis.
Another eponymous variant is the Leader's hernia. This is defined strictly by its anatomical content. The hernia sac contains a Meckel's diverticulum, a congenital true diverticulum of the distal ileum present in roughly 2% of the population.
But the anatomical variant that requires the highest degree of operative vigilance is the Madel's hernia. This involves a complex geometric herniation of the bowel forming a W configuration.
The mechanics of Madel's are treacherous. Two distinct loops of bowel descend into the hernia sac, forming the outer legs of the W. However, the intermediate loop connecting them remains trapped within the main abdominal cavity.
The profound surgical trap occurs during exploration. The fascial ring is compressing the base of all these loops. The mesentery supplying the intermediate intra-abdominal loop is tightly kinked and compressed at the ring.
When the surgeon opens the hernia sac in the groin, the two visible loops may appear congested but viable. However, the unseen intermediate loop remaining inside the abdomen is undergoing severe, strangulating ischemia due to the mesenteric vascular occlusion.
If the surgeon simply reduces the visible loops without actively extracting and meticulously inspecting the entire length of the involved bowel, they will unknowingly leave a segment of frankly necrotic intestine within the peritoneal cavity, resulting in catastrophic postoperative peritonitis.
Moving away from the typical inguinal and femoral locations, we have the Laguier's hernia, a rare variant where the defect completely bypasses the femoral ring and protrudes directly through the aponeurotic fibers of the lacunar ligament itself.
And finally, the Spigelian hernia, which is entirely distinct from the myopectineal orifice. This defect occurs laterally along the anterior abdominal wall, specifically through the linea semilunaris, the lateral aponeurotic border of the rectus abdominis muscle.
The Spigelian hernia is notoriously difficult to diagnose clinically because it is typically an interparietal hernia. The peritoneal sac protrudes through the transversus abdominis and internal oblique aponeuroses, but remains contained deep to the intact aponeurosis of the external oblique.
Because it does not breach the superficial fascia, it rarely presents as a palpable subcutaneous mass. The patient presents with localized, severe point tenderness lateral to the rectus sheath, often requiring cross-sectional imaging, like a CT scan with Valsalva maneuvers, to definitively identify the interparietal fascial defect.
We have covered an immense amount of biomechanical and surgical ground today. When you synthesize the entirety of this masterclass, it charts a brilliant trajectory of surgical logic.
It absolutely does. We traced the initial era of anatomical discovery with Bassini and Shouldice, where surgeons commanded native tissues, relying on meticulous fascial reconstruction and the modulation of physiological tension to reinforce the wall.
We analyzed the paradigm shift initiated by Lichtenstein, who recognized the inherent biomechanical limits of attenuated fascia and introduced inert synthetic macroporous scaffolds, trading physiological tension for foreign body fibrotic integration.
And we concluded with the contemporary era of laparoscopy TATP and TAPP, which utilizes the exact intra-abdominal hydraulic pressure that causes hernias to universally seal the entire myopectoneal orifice of Frouchot from the preperitoneal space.
It perfectly illustrates that surgery is an ongoing, dynamic dialogue between human anatomy and the limits of material engineering. And to close out this deep dive, I want to pose a theoretical extrapolation based on the specific limitations of our current materials. We discussed that in the presence of gross bacterial contamination, such as a gangrenous bowel and a strangulated hernia, the use of permanent synthetic polypropylene mesh is absolutely contraindicated because the avascular plastic inevitably harbors chronic biofilm.
In these extreme cases, surgeons are forced to rely on high-tension autologous repairs or utilize incredibly expensive biologically derived resorbable extracellular matrices.
So if you project the trajectory of this 150-year surgical evolution forward, it raises a profound question about the future of herniology. We evolved from forcing pathological native tissues together under tension to implanting permanent synthetic foreign bodies to eliminate that tension, to elegantly hiding those synthetics deep within the preperitoneal fascial planes.
But given the chronic inflammatory risks and infection liabilities inherent to any permanent synthetic implant, is the final evolution of hernia repair a complete departure from permanent materials?
Could the future standard of care be a fully resorbable, highly engineered biological scaffold tailored perfectly to the dimensions of Frouchot's orifice? A matrix that possesses the immediate tensile strength to resist intra-abdominal pressure, but serves purely as a temporary biologically active lattice.
It would actively recruit the patient's native fibroblasts and stem cells, directing them to deposit a flawless neofascial posterior wall, and once that mature collagen matrix is established, the biological scaffold completely dissolves via enzymatic degradation, leaving behind zero synthetic footprint.
It would be the ultimate synthesis of the tension-free philosophy and autologous tissue regeneration, a completely biological restoration of structural integrity. It is the perfect biomechanical endpoint to strive for. Thank you for joining us as we navigated the intricate fascial planes and surgical logic of the inguinal canal. We will see you on the next deep dive.